Welcome, welcome. My name is Dr. Jamie Kunkle, and I'll be speaking to you about the lovely world of complicated neurologic conditions associated with Lyme disease and Lyme syndrome and all the lovely terminology and nomenclature and various things that get thrown around in this world. A little bit about myself before we begin. I've been practicing with Gordon Medical Associates since 2021. I've been practicing for about 11 years now, specialty in complex chronic illness. I love puzzles and complicated things as it goes, and I've taken a special interest in neuroscience and neurologic conditions. But I think as a naturopathic physician, naturopathic doctor, thinking of these type of conditions from a multi-systemic approach, multiple body systems become dysregulated is a really important thing to remember. So connecting dots, solving puzzles is what we do. So let's get started. So this is just the overview. We're going to discuss a lot of different manifestations of neurologic Lyme disease, some of the challenges in differentiating these symptoms and figuring out where they're coming from and what the cause of them is and how to best treat them. We're going to discuss some of the overlaps with common diagnoses, conditions, and things like this that Lyme can be a cause of, so to speak. And Q&A at the very end is going to be real fun, as it always is. We have a great audience usually here, and I'm sure it's the same today. So neuroborreliosis is referring really to Lyme Borrelia, Borrelia burgdorferi, and all those guys. There's a lot of Borrelia species technically, but the original Lyme that was discovered, quote unquote, in 1975 into 1978, was referring to Borrelia burgdorferi. And in those cases, acute Lyme manifestations following a tick bite often, and according to definitions, the presence of an erythema migrans rash, the annular rash, the common rash that people see, the bullseye, was often followed in some percentage of folks by neurologic symptoms, meningoencephalitis, like meningitis, encephalitis, cranial neuropathies, so cranial nerve neuropathies. We'll talk about those. And sometimes associated with inflammation in the heart, carditis, or arthritis. So some pretty severe findings there when we didn't really know much about the disease process. In the modern day, I'd say the term neurolyme gets thrown around quite a bit. If you wanted to officially call somebody neuroborreliosis, you'd have to theoretically diagnose it with a cerebral spinal fluid analysis that involves a very invasive spinal tap, which isn't always fun. May be necessary sometimes, especially in acute manifestations if people are hospitalized or something like this. This is not what we usually see in our practice, though. Although I will talk about the importance of catching tick bites early and treating this stuff early to avoid some of the more complex manifestations. So urgent emergent manifestations may have a more straightforward treatment in some ways. Chronic manifestations may not have so much of a straightforward treatment, and they may not be as dangerous and life-threatening, but they are not a great quality of life nonetheless. So most people just diagnose this stuff more clinically these days, it seems, and there's a lot of reasons why that's the case. There's still a lot of limitations in laboratory assessment, of course, too, and that's another reason outside of cerebral spinal fluid analysis. Even finding evidence of these infections in some people is still difficult. But there is new testing on the horizon. Hooray. And they had mentioned that maybe 3 to 15% of tick bites or acute Lyme could involve these neurologic manifestations. They say if Lyme really truly gets into the brain, it's maybe a small percentage of people in the acute phase. In chronic Lyme, though, there are almost always at least some level of neurologic manifestation. Very rarely there are not. Occasionally you'll just see inflammation in the joints and the connective tissue, let's just say. It's possible, but chronic fatigue even, is that a neurologic manifestation? Probably. There's a lot more than that. And there's this new definition, so to speak, with quote unquote chronic Lyme of post-treatment Lyme disease syndrome. So people who've gone through antibiotic treatment or have been treated for quote unquote acute Lyme and still have symptoms or sequelae symptoms. And I'll comment more on that a little bit later. But one of the manifestations of PTLDS, as it's defined, is neurologic manifestation. Persistent cognitive impairment, fatigue, things of this nature, and it can be more severe than that too, but enough to be debilitating nonetheless. So I think the reason why this terminology came to be, as most things with Lyme, it's a lot of politics probably, but it makes a certain amount of sense. It's kind of a meet halfway point. A lot of people still don't believe that chronic Lyme exists, that there's chronic infection of Lyme disease. It's either you got treated and you don't have it anymore, you didn't treat it, and sometimes you don't have it anymore, apparently, to some sources, or you forgot to treat it because you didn't notice it early on and you treated it later and you still have symptoms. It's all like kind of PTLDS at the end of the day. But the good news is about this nomenclature and this research is it is at least somewhat differentiating what they used to be terming neuropsychiatric illness in chronic Lyme. It's all in your head. You're crazy. You're just depressed, because there are a lot of overlapping symptoms with major depressive disorder, for example. And I'll talk about the neuropsychiatric manifestations here, of course, too. You can have a psychiatric illness that's caused or potentiated, at the very least, at the very minimum, by physiologic or physical illness like infection. So perhaps this is a step in the right direction, but if it gets people the help that they need, the acknowledgement, understanding that some of these people are disabled, it might be beneficial ultimately. So what are the most common symptoms of quote unquote neuroborreliosis or neuro-Lyme? And I just wanted to quickly qualify too that when I say, and most people say Lyme, they may also mean co-infections. They may not just mean Borrelia burgdorferi or Borrelia whatever. You know, there's a bunch of Borrelias out there. Tick-borne relapsing fever Borrelias, Borrelia miyamoti, whatever. A lot of other things affect the nervous system too. Bartonella, Babesia. I will try to go through some of those, but generally speaking, this talk was sort of focused on neuroborreliosis because Lyme itself is a persistent force in and of itself that allows those co-infections and other infections in the system to thrive. It creates a pretty profound dysregulation in the immune system at large, and that can manifest in multiple different ways, but I'm just focusing on that guy. So of course, there's a lot of fatigue. Chronic fatigue syndrome doesn't really mean anything as a diagnosis. It's just a syndrome diagnosis, and there's a whole bunch of those out there. And in conventional Western medicine, we don't like to finish that diagnosis very well. Like in Chinese medicine, in my training, it was this diagnosis, like say chronic fatigue or the symptom due to ... Due to what? What is the etiologic factor? What is the cause? And can you treat the cause? There may be more than one cause. So the title diagnosis itself doesn't help very much, but you can see a whole bunch of these in here, like nerve pain or chronic pain syndromes, paresis or paresthesias, or cranial nerve neuropathies, or palsies, or whatever, all this kind of stuff, migraine headaches, you know, all those things are just syndromes. They're just signs and symptoms collectively together. And most of the time they're treated with symptomatic agents. It's not always, it's okay to symptomatically treat some of these symptoms, but you also have to have a long-term plan for understanding where the causes come from, so to speak. So Lyme has been termed as the great mimic for a variety of reasons. I suppose it's for similar reasons as I've already mentioned. A lot of people get more syndrome diagnoses that sound a little scarier, and the causes aren't looked at further. A lot of these are autoimmune conditions, or termed autoimmune conditions. Some of them aren't, but many of them are. And autoimmune manifestations of Lyme disease is a very common presentation, and it can come in many forms. Sometimes it looks like rheumatoid arthritis. Sometimes it looks like Parkinsonian illness. Sometimes it might look like MS. Sometimes it might look like autoimmune thyroid. It might look like all kinds of things. And so we have to consider that an autoimmune manifestation of Lyme disease, not an autoimmune condition per se, which is a diagnosis that rules out current causes officially. So here's a whole bunch of them. Yeah. We'll talk about some of these hopefully as we go. I put POTS dysautonomia down here because some people do believe that's a possible autoimmune etiology. There's some structural contributions to POTS manifestation too. That's postural orthostatic tachycardia syndrome, and there's a whole bunch of other autonomic dysregulation manifestations in Lyme, and that's part of your nervous system. the unconscious regulatory system of your body is your autonomic system. The two states being fight, flight, freeze, driven by adrenaline largely, and then rest, digest, sleep, that kind of stuff, driven by acetylcholine and all this kind of thing. So neuropsychiatric presentations, I think this is very important. I've already kind of alluded to this, that inflammation in the brain, or whether it's primary or secondary, whether it's like an infection in the brain or autoimmune inflammation causing encephalitis or neural inflammation, or whether it's some other type of dysregulation, leads to inflammation in the brain, breakdown of blood-brain barrier. So many different mechanisms may exist here. Folks will often present with psychiatric or neuropsychiatric symptoms and or diagnoses, some of them on the scarier end of the plane, schizophrenia, schizoaffective. I've had folks that have heard voices and different things like this. It is quite possible to manifest that way. And there's that old book, Brain on Fire, from that reporter who, quote unquote, went crazy and ended up being hospitalized with an acute infection. And the brain on fire was the problem. The inflammation in the brain was creating that neuropsychiatric response. Addiction's in there too. Surprise, surprise. People self-medicate sometimes whenever their brain's not regulating properly. So we should consider that too. Obsessive compulsive disorders, or OCD, quite common, an inflammatory response. The brain can get stuck in some of these negative loops though too. So even when you remove the inflammation, it doesn't always like fix the problem per se, but that's whenever your other therapies might become more effective and more valuable, like classic counseling therapy and other psychotherapies and even sometimes medications. Other comments, so some more comments on secondary responses in neurologic Lyme, and I just sort of been harping on this autoimmune reaction. One of the theories, just to be clear, is that the surface protein of Lyme may look like some of our tissues in our body. So the same thing can happen with strep, apparently. I believe it's like the M protein of strep. We've known for a long time strep can cause autoimmune manifestations in multiple areas of the body, between the kidneys, the heart, the joints, and the brain. Same thing can happen with Lyme, incidentally. So those responses could happen peripherally, meaning outside of the nervous system, but those antibodies could theoretically through the bloodstream enter into the nervous system and cause problems. So that is not necessarily always a direct infection effect. And if you can deal with these antibodies properly, sometimes the neurologic symptoms calm down. So there's pandas in kids. Pandas is associated with strep. PANS is just sort of a catch-all of any other infections. Lyme can be included in that. So can Bartonella. I've seen Babesia in that range too, honestly. The herpes viruses we'll talk about probably, like EBV, CMV, HHV6, and all those guys too. And now they put a new term to the adult version of some of this associated with Lyme, and they called it ANDLS, adult neuropsychiatric disorder associated with Lyme. So we got more acronyms to put labels on things. Doesn't matter how much we label, if we want to make sure we're understanding and treating correctly. So we'll get to that hopefully. Autoimmune encephalitis doesn't always present with psychiatric disturbances. I just wanted to make a caveat to that. It may be more fatigue, really severe brain fog. It might be, excessive sleepiness or excessive insomnia. It could come in many different forms. Common secondary syndromes also, I wanted to put a plug in here for some of my patients. So some of these syndromes like mast cell disorders, autonomic dysregulation, and even structural and connective tissue issues, some of them might be constitutional. Some people may be born with some of these, not always. They can also be acquired or worsened or potentiated by chronic inflammation. So a lot of these tick-borne infections can affect all these things. Lyme, Borrelia, Bartonella, Babesia. I always, the 3 Bs I like to, associate here, but any of them really. Bartonella especially likes to create a trifecta disturbance between mast cell disorder, autonomic dysregulation, and structural worsening instability syndromes like hypermobility or EDS, selective joint instability, worsening trauma areas that have been injured or damaged in some way, like say a whiplash injury in the neck. And people get Lyme and inflammation in the connective tissue worsens and the neck becomes more unstable over time. That's a pretty severe manifestation, but you better bet there's neurologic symptoms that manifest in that type of case, because there's quite a lot of nerves and important vasculature that is in the neck region. I mentioned dysautonomia, most common being POTS, but there's a lot of other manifestations. A lot of my patients do just get like these adrenaline type surges, as they just sort of describe them, but chest pain, palpitations, and really uncomfortable heart sensations that aren't necessarily Lyme carditis. They may be more coming from the nervous system, and they may create rhythm changes and problems like that. So, and some of the worst cases I've seen in structural changes have also included like cerebral spinal fluid leakage, which I know sounds pretty scary too. But if there's a breakdown in the meninges and some of those protective layers in the system, and also if there's a trauma on top of it, it can be pretty severe. Yeah. Of course, mitochondria need not be neglected, as that is the energy producing system in each one of your cells in your body, processes the food you eat into fuel. If it's not working correctly, you better bet you're going to be fatigued or things aren't going to work right. The muscles have the highest amount, and the brain is kind of up there or second at the very least. And there's, of course, of the theory of cell danger response involving the mitochondria and its change in activity and metabolism and production of energy in response to what it perceives as a chronic illness. Infection could be one of those causes or triggers, so can toxins and many other things. It's even in some cancer models, we could say, are autoimmune. The mitochondria change the way they operate. And that might be very important actually for understanding these things in the future. But there's neurologic symptoms there too. Don't neglect the gut. A lot of traditional systems really drive this home, I think, and we have to come back to that. We're learning more complexities within the microbiome system, the psychobiome, as they call it. What's affecting the brain from the gut is very important. That's where your metabolism begins, how your body, how those bugs react to the food that you eat, and what happens from there. It's a very important process, even for the brain, the gut barrier, what toxins get in, what bugs get in, all of that is important, liver function, everything. I talked about secondary and co-infections. It's probably a big talk in and of itself. But yes, they absolutely affect the brain. They affect the complexity of the syndrome. They affect the treatment. They affect everything. And I listed out a few of the ones that I would, maybe pay some close attention to, but it's certainly not limited to this list. But these are the ones that can definitely affect neurologic manifestations. Trauma. Trauma comes in many forms. Physical trauma, I've already mentioned how it can affect the integrity of the structural system. Emotional trauma, early childhood trauma is all very important too. It's chicken and egg sometimes with people. If they've had a lot of early childhood traumas, are they more susceptible to these illnesses, neurologically speaking? Maybe. At the same time, if they have neuroinflammation, their trauma response may be altered or changed. There may be a higher response or a higher activity. It doesn't matter necessarily all the time what the trauma is, it's how the brain responds to the trauma. That's what we're learning. So not everybody has to go out to war to get, PTSD anymore. It can happen right at home, right here. So very important though for healing the brain, and some of the associated factors of that are impaired BDNF, the ability for the brain to heal on a regular basis. We used to think kids could only have plastic, ever-changing, adapting brains, but till the day we die, we have a potential for plasticity. We always have a potential to change the brain. Inflammation affects this potential. So we can get very stuck in negative loops, as I mentioned, in our brain. We can get stuck in processes that aren't serving us. That's a whole talk in and of itself too. So instead of just listing out a bunch of treatments, I kind of listed out here a bunch of principles on how to approach complex neuro-Lyme presentations from my experience and the experience of others that I've learned from around me, and the great leaders of our field of chronic illness have presented a lot of these ideas too. So they're not all my own, but worth reading through them a little bit here. Of course, I said already, early treatment is one of the best ways to treat neuro-Lyme. It's take tick bites seriously. You don't have to always have an EM rash. It doesn't always matter exactly if it was on there for 2 hours or 30 minutes. I've seen manifestations in shorter duration, quote unquote, tick bites too. So if it's symptomatic, if you develop a strange flu-like illness soon after a tick bite, it may be a couple weeks even, it may be delayed longer, take it seriously. If you're not sure, contact a Lyme literate practitioner, LLMD, LLND, LLNP, whatever. You could, somebody that's licensed and either know somebody or can possibly give you prescriptions if required, if the level of illness meets the need for prescriptions, symptomatic. And in general, it's good to know somebody that has that literacy, that understands the complexities of Lyme outside the politics of Lyme. I think that's very important. Or maybe understands the politics, but also is outside the box a little bit in keeping with the current guidelines, because the current guidelines haven't really been serving us, unfortunately. I'd hate to say that, but they just haven't been, and everybody knows that who's in the game. Takes team. I think with complex neurologic Lyme illness, I work with other providers too to get other opinions. Either I'm working with a psychiatrist if it's psychiatric, I'm working with a neurologist if it's more severe neurologic. It's good to be able to talk to your care team. It's good if your care team communicates. It's very hard to achieve that this day and age. I've come to realize everybody's too busy. There has to be an effort made on all parties. But I think if you can achieve that somehow, it's more heads in the game. No pun intended there, but it's more brains, better, I think, for complex neurologic syndromes. Also, for chronic syndromes, it may not be so straightforward to just go kill everything. I've had plenty of people who killing dysregulates them more. You have to prepare them for killing. It's like what Dr. Parpia says about the whole pre-tox or preparation for treatment, whether it be detoxification or whether it be infection treatment. There's a preparatory process that may be necessary. So maybe don't just rush into it if you have a pretty severe neurologic condition, because that can be, you don't want to cause destructive damage to the nervous system. You want to know what you're dealing with. So do the proper testing, do the proper physical examination, do the proper workup before you rush in too quickly into killing. Because there may be other routes too. Maybe more straightforward in the acute case. So, by all means, sometimes just hitting it with 3 antibiotics makes sense in the acute phase. Always, always, don't neglect toxins. We live in a toxic world. Every generation is more toxic. Took me a little while in my career, I don't know how long, maybe a little while, to really truly come around to the notion that toxins may be one of the higher drivers of chronic illness. I don't know why I was resistant. I thought I could just, find some infections and pick them off, and that would be enough. And sometimes it was, and sometimes it is. This day and age, though, with the patient population I see, and then in the age of COVID, which I'll talk about, it's not as straightforward there. There's usually some need to do detox work and to do investigation, and it's not always mold. Mold's a lot of it. It's not always mold, though. Because one can beg the question, why are we having issues with mold when we've lived amongst mold for so long? Why are we having such big issues? It may be a toxic burden issue. There may be other reasons and influences. And there's obviously some suggested genetics and things like that too. But a lot of these newer chemicals, we haven't seen them for more than 100 years, some of them even less. We haven't had enough time for adaptation as humans. So just remember those principles, because these things do affect the brain. If they get into the brain, they're definitely affecting the brain. If they're not in the brain, if they're affecting the gut and the liver and other things, they can secondarily affect the brain in the long term, because all the systems are interconnected. Remember that. COVID, the great elephant in the room. The age of COVID has made everything more complicated. I've seen several neurologic cases now of multiple positive tick-borne infections only presenting, only manifesting, only showing symptoms after COVID illness or COVID vaccination injury. These people probably had these infections, harbored them for a long time, and didn't have disease process. And now they have become dysregulated. These infections are rising, have been rising, and there's often a lot of sensitivities associated with this too. So these can be some of the toughest cases I've seen. But even if somebody says, well, COVID didn't really faze me, it didn't bother me, just remember, sometimes there's a delayed onset of dysregulation around COVID, and some of it could be mast cell disorder. Some of it could be, as I mentioned, reactivation of infections. Some of it could be vascular inflammation or coagulopathies, thickening of the blood, a higher fibrin. There's a theory of quote unquote microclots, fibrin amyloid aggregates in the blood that can affect the capillaries and the microcirculation in the brain. There's a whole world there worth looking at if that hasn't been considered just because you didn't have a really clear post-viral response, or you did okay with the vaccine, you felt bad for 3 or 5 days, but you were quote unquote fine after that. But then 3 to 6 months later, you started to see dysregulation. I've seen delayed onset in these cases, so be attentive to the COVID possibility. Hormones, don't neglect those either. Yeah, there's the big three groups that you really have to pay attention to, which is your adrenals, your thyroid, and your sex hormones, maybe in that order, but not always. But they all are very important for the brain. They play a regulatory role. The central computer, your hypothalamus, pituitary axis, all that is in your brain. So you better bet they get affected. And that's been recognized in traumatic brain injury and post-COVID, which looks like traumatic brain injury. So there's a lot in the hormone systems too. So anytime there's neural inflammation in there, you might want to check those guys out too, because it's not always a primary issue like they have thyroiditis or thyroid inflammation. It might be central computer issue. You might see issues with growth hormone, and I mentioned melatonin. There's MSH and mold and other things. There's a lot of stuff out there. Insulin resistance, insulin sensitivities, all the above. I mentioned sensitivity responses. They do pose a obstacle to treatment. They can be mast cell mediated. They can have other mediations. I've seen these ill-defined autoimmune manifestations become sort of destructive too. And is it always mast cell? Maybe it is. To some degree, maybe not always. MCS, multiple chemical sensitivities, seems to be associated with mast cell, but not completely well defined. EHS or electrohypersensitivities, like EMF type sensitivities, those do exist too for some people. So, and oftentimes their manifestations are first in the nervous system, and they can be pretty acute in some cases, or delayed in the case of like you treat somebody and they have kind of a delayed immune blow up down the line of treatment, not necessarily the day of or the day after. I already mentioned structural stuff, could drive that on home. It's good to recognize structure function issues. I have a lot of patients with craniocervical instability. It's not that common, but we seem to collect them apparently. Tethered cord syndrome, stuff like this. The stuff you see with like EDS, Ehlers-Danlos syndrome, and hypermobility commonly can sometimes develop without people having that constitutional prearrangement that's really frank obvious with genetic testing and Bateman score or whatever it is that people do to diagnose it. I mentioned trauma all day long, but brain retraining programs can be quite valuable, and there's some newer research on supporting, once again, plasticity treatments, BDNF, and other things for chronic Lyme and chronic neurolyme manifestations. And there's time and a place for regenerative therapies too. So you don't always have to rush into those, but although I've seen exosomes, for example, reduce neural inflammation in a short term, they're an acellular material, not like stem cells. Sometimes people with sensitivities don't always do as well as stem cells, but exosomes, I've seen some good tolerance. They're just expensive, of course, but if you're able to tolerate that stuff, great. Hyperbaric oxygen, I love oxygen treatments all around. Sometimes we'll use ozone or whatever, but that's good too. Hyperbaric though is pretty rad because the pressure and an oxygen treatment, so you get that microcirculation open and you get the brain reoxygenated. In a lot of functional neuroimaging in chronic neurologic Lyme and all that, kind of looks like the depressive brain too. There's lower circulation. That's like the SPECT scan that Amen does in those type of people. So bringing oxygen back to the brain in one form or another is a fundamental principle that's worth, a reminder. Sometimes that may be through quote unquote fibrinolytic therapies like nattokinase, lumbrokinase, things we use for the post-COVID illnesses too. Some infections in Lyme also manifest that way. Wanted to put a little plug in for that since I didn't spend a lot of time on it, but it's an important thing I recognize and I test all the time in my patients. And don't give up on hope. Keep hope alive if you can in these cases. It sometimes takes a little more than just saying that, of course. Community support, spiritual support. There's a lot of other ways that you can get support to keep hope alive. Hopefully having a good practitioner and a good team, once again, that communicates with each other may also help with hope. Having some small wins will also help too. It is hard if there's repetitive treatment difficulties. But outcomes are often improved if that hope is kept alive. And mindset is very important. Mind body is a really powerful thing, really powerful combination. That's why I encourage people to do brain retraining and to do therapy with somebody that maybe understands complex chronic illnesses a little bit more, and many other interventions. And social support is really key too, of course. Not everybody always has the support of their family in these types of cases, and it can be very isolating. And that is not good for the brain. We are not an isolated species. We are social. We do better and thrive better being around people usually. And in the midst of an illness, especially neurologic illness with a lot of brain fog and neural inflammation and everything, it can feel very taxing to be around people sometimes too. So the isolation sometimes happens gradually over time, just, because it's difficult. Maybe stimuli is difficult. Maybe there are sensory disturbances, light, sound, touch, all of it. There's a lot of reasons, but if we can find a way to remain and connected, I think it can really make a big difference. Okay, so I kind of blasted through that, but I wanted to spend some time with questions because there's a lot I could talk about here, and I could also review some more cases if needed.
Great, thanks, Dr. Kunkle. All right, if you want to stop sharing your screen.
Right on.
Okay. How much reactivation of Lyme have you seen after COVID? And are they presenting as neuro Lyme or as other manifestations?
I think the worst cases I've seen have really presented like Lyme, I have to say, but it's been on my radar for other cases. It's just that most people with post-COVID have some kind of neurologic symptom, whether it's like it's presenting like chronic fatigue ME, like myalgic encephalomyelitis, chronic fatigue syndrome, or dysautonomia, like POTS or those types of things. I mean, there's usually some sort of neurologic illness there, but occasionally it might not be primarily neurologic, but I'll keep Lyme on my radar. Some of the old inflammation cytokine screens were trying to differentiate that, but they're not perfect, like Patterson's work. I can talk more about that if needed, but mostly neurologic that I've seen. And it's fairly common. It's not everybody, but there's a certain segment for sure, and they are sometimes the harder ones to treat in my experience.
What dietary approaches do you recommend or advise against for Lyme?
Oh yeah, that's a really good question because some people do really well with like say keto adaptation because ketones are very anti-inflammatory, and sometimes having that low sugar diet or that low fermentation diet, if the microbiome's all screwy, might be good. It might be good, but if you're getting constipated and not detoxing very well, it might not be good. And keto diets are very detoxifying in a lot of ways, at least in the first phases, and you can burn a lot of fat and lose a lot of muscle if you don't do them properly. So they're only really done under medical supervision in my experience, but they can be powerful for the brain in some cases. They were originally studied in seizure disorders, so it makes a certain amount of sense. And I have seen seizure manifestations in Lyme in some cases, so I've used that. Otherwise, I mean, paleo is a classic fallback, or if there's autoimmune manifestations, maybe an AIP paleo type setup. Some people have benefited from carnivore. Sometimes in the hypermobility and connective tissue issue people, they do better with a higher carnivore diet because they need connective tissue support more, or their iron is completely tanked, and that can happen to anybody. And that's a low fermentation diet too, and some people do really well with it. So it's not a one size fits all. I'll usually try to gauge that with the constitution of the individual and determine what makes the most sense for them. And if they have a cool nutritionist that understands neuro illness, great.
That would be the best. There are some questions coming into the chat, and please remember to put the questions in the Q&A so we don't miss any of them. All right, the next one here is, do you see neuroflare in chronic Lyme patients after they've received the vaccine?
Yes. Not everybody who gets the vaccine I see that in, but I will say that it is fairly common, and it is one of the harder, more difficult manifestations in post-COVID vaccine injury. Some people just feel like body symptoms for a couple of days, and that isn't a big deal. But if it's lasting like 2 weeks, that might be a little bit concerning, or longer than that, or that delayed onset. But the worst cases I've definitely seen have been on the neurologic spectrum.
Among those conditions that highly overlap with acute or chronic Lyme/co-infections from tick bites, which ones are most confused or mistaken as acute or chronic Lyme, and vice versa?
That's a good question. In my experience, I mean, what's specific, It's like, I think that if I see like an MS or an ill-defined MS patient, I might be like really suspicious of Lyme, because if it's like frank MS, sometimes it's kind of ambiguous. Like what I mean by that is they've had all the markers and all the usual, you know, checked boxes of MS, but I've seen like vaguely defined MS that very much looks like Lyme. And I could say the same thing for Parkinsonian illness, where it's sort of vaguely defined. We think it's Parkinson's, but we're not sure it's Parkinson's. So, you know, a lot of flags go off for me when it's like this ill-defined thing. It doesn't fit the literature, but it looks like that. But a lot of times, even specialists aren't even willing to give these people the diagnoses. So they don't even fall into a box that's, you know, good enough to give them conventional care. They're just like, you're sort of like this, and we don't really know what to do with that.
Have you seen complete and durable resolution of symptoms and or complete and durable resolution of neuroborreliosis? And if so, in what percentage of patients?
Yeah, and I think that depends on a multitude of factors. And I have to admit that our patient population has often seen a few other doctors and has gone through a lot of regular, typical treatments. So I think some of my bias in reporting this is on, you know, a unique population that I see that doesn't fall into those boxes. So in the cases of the people I see, there's usually more than one system that's dysregulated, and there often is like either some sort of like autoimmune type manifestation or something really stuck. Maybe it's a mast cell piece or something else, or maybe there's a genetic aspect that's really impeding the healing process. But I think that if you were to catch a person within the first year or like within a reasonable amount of time of a quote unquote straightforward tick bite, if those exist anymore, I feel like the prognosis is pretty good with the correct treatment. And that may, if there's limitations in oral antimicrobial usage, IV is technically indicated or appropriate for neurologic manifestations if you want to try to drive medications like physically into the brain. So I think there's good outcomes there if it's more in that straightforward spectrum. But once again, I haven't seen those folks for a little while since I've been at Gordon Medical.
Can dysautonomia and POTS be signs of undertreatment?
In some cases, yes, because I like to see those things recover with treatment, that when the inflammation is lower, those symptoms often improve. If you do serial orthostatic assessment, like seeing how people respond to positional changes in their heart rate and blood pressure over the course of treatment, you should see improvement functionally. And they should also report that. I get less dizzy, lightheaded, or I get less palpitations or whatever. So yes, that should improve. But there are some exceptions, I guess. Like for example, in some women, there's a theory floated around now, and there may be some validity to it, that pelvic congestion syndrome is a cause of POTS. It's suggesting that there's a physical force in the vascular system that is causing the problem. And in some of those women, you know, they were corrected through surgical or stent placement intervention, which is really interesting. So I would definitely not assume just because the POTS isn't going away that it's the treatment's inadequate. If you're feeling better in other ways, you have to roll out structural contributions is my take home, because there could actually be other factors, or that autoimmune theory, though I think that should also calm down theoretically, but you never know.
So there's a question about ozone therapy and how is the ozone provided? Is it IV into the blood? Does it reach to kill the spirochetes and kill any good in the process?
Fair enough. The cool thing is we don't usually see ozone causing a immense like dysbiosis or dysregulation of good flora and biome. And this is coming from having also done, you know, rectal ozone for people, you know, straight into the large intestine, or it does beeline a little bit into the veins and into the vascular system through the rectal pathways, to be fair. But as far as blood ozonation goes, I haven't really seen that be a problem either. We mostly use blood ozonation with a specialized machine that, you know, assures that it's being safely applied. It's just ozonating the blood directly, and then that blood is coming, your own blood is coming back into your body from there. So depending on how concentrated that is, it's a different pass system. So yes, it does, it has so many mechanisms, ozone, but one of the most important things to think about is, yes, it is directly antimicrobial inside of the cell. It uses your natural systems to kind of hyperoxidize these infections through hydrogen peroxide and different things, but it also stimulates your immune system response. So if you're a person that tends to have more of a sluggish immunity manifestation, especially of chronic Lyme, because Lyme is immune suppressive in a lot of people, ozone may be appropriate. So you have to gauge if it's appropriate for the individual, because oxidative therapies might be too much for some people to handle, at least in the first phases of treatment.
Great. Why might Lyme not show up in cerebral spinal fluid despite a patient having neurological manifestations of chronic Lyme?
Well, Lyme likes to hide a lot. That's one short answer. It doesn't really hang out in the blood very long either, even, in acute phase. It might, and it's a fast-moving organism too. So, you may not find evidence directly, and you may see seronegative, or, you may not see immune reactions in the cerebral spinal fluid either that are really truly indicative. So, there's a lot of theories as to why that happens, but it is really good at sort of being a chameleon in some ways, and it is really sort of good at telling the immune system nothing to see here and go back to your, stations, so to speak, too. So there's a lot of reasons why it can cause turmoil, but it's not in a way that's really easily recognized. It's a highly adaptive organism. That's really the short answer. It's more adaptive than most organisms that we get in contact with, which is why I spend so much time talking about it.
Is there a recommended priority order when you're talking about detox for EMFs, heavy metals, et cetera? Is there an order that you go in?
I think that you have to think if somebody is being currently exposed to something, that would be your first priority. So if there's like a moldy home that somebody's living in, it goes without saying that that would be your first step before you would ever touch detoxification. So you have to kind of gauge the environment of an individual, like where they're living and how that's affecting them in all those different ways I mentioned, not just, physically speaking, but if it was a toxin discussion, that would be the thing I would do. And whether I was doing heavy metals or whether I was doing molds, I would be trying to look into that. So I'd be looking for clues and ideas, and the testing, which is also limited, mind you, with mycotoxins, but I would be looking for clue-ins to see if it was a current issue before I would start detoxing. In some people, it makes sense to do the detox work before you treat, because a lot of them have come in already, have tried to treat, and it hasn't worked out for them. If you're too toxic and you try to treat, it's just adding more toxin into the system. Really, it's either the drugs are toxic or causing problems or dysregulation in detox systems, or the organism may be producing endotoxins or something too. So it's kind of a combo pack that you really don't want to get into with the brain sometimes. A lot of my patients do better if they've either done detox work before treatment with the antimicrobials or did coexisting detox work while you're doing antimicrobial treatment as part of a balanced breakfast. So, it's kind of meshing them together. So I don't have an algorithm. I gauge the person, but and see sort of where they've been and where we think we can go. And sometimes pulsed therapies with antibiotics can be beneficial to reduce toxicity too, or antimicrobials in general.
What's your view on hypothermia treatment?
Hyper or hypo?
Hyper.
Hyper. Oh yeah, so in this country, we're not allowed to call it that. First of all, it's called sauna. In
I
other
didn't say
countries,
that then.
okay. In other countries, there is a hyperthermia therapy, like the studies in Germany. But yes, according to their studies, it has been promising and helpful. And I think I use sauna in this country relatively frequently uh, to help support therapy. We just start off really slow and low with people that are very sensitive, of course, and it can improve the outcomes of your antimicrobial treatment, as according to some studies, and it can, of course, help with detoxification. And I have a lot of people that just have this sense that I'm not warm. I can't get warm. I'm cold. Like my temperature is 96 degrees or whatever. There's just this sense of like poor regulation in that system. These are people that don't fever. I mean, they say relapsing fever, but really, when was the last time they fevered? It's been a long time. Some of them do get relapsing fevers, but a lot of them don't fever very well. So you can get the immune system to perk up a little bit doing that too. It's incredibly powerful. It can be in the form of an Epsom salt bath too. It doesn't have to be a infrared sauna, or you can get those cheap infrared saunas with your head sticking out of them, from online platforms. There's a lot of different ways you can do it.
How do I know if it's Lyme or mold? I can't walk or talk. I have ataxia-like symptoms, Lyme bands 58 and 93. I have double vision, and doctor wants me to do IV antibiotics.
Hmm. That's a really good question. I mean, I would run through my usual testing to try to get some clue-ins of whether it looks more moldy to me. One test I use sometimes for these cases, and it's far from perfect, but I'm just going to throw it out there, is the MyMyco, which is the IgE and IgG antibody response to mycotoxins. And if those are like through the freaking roof, I would be sort of a little bit, concerned about throwing antibiotics in there right then and there. or I would do it in like the slowest manner possible if I felt it was like a rescue situation. Occasionally, antibiotics could be thought of in a what one would consider a more severe manifestation or more urgent emergent situation, but I can't completely comment to that, just that I would try to do some of my testing to differentiate if possible.
Great. Do you see a prevalence or correlation of viruses, CMV, in your Lyme patients? How to differentiate between neuroborreliosis and internal VZV?
Yeah, fair enough. One of my favorite tests, and it doesn't work with everybody because none of them do, but Infecto Labs I like because it's lymphocyte response testing. So it looks at your T cells or your innate immune system response. So it tries to tell you in that moment what your immune system is paying a lot of attention to, and it gives you sort of like a semi-quantification of that. It doesn't work for everybody, but it is useful for the viruses, because if you just do classic antibody testing with the viruses, oftentimes they come up super freaking high, chronically, constantly, for years and years and years on end. And these viruses can replicate anytime through the course of our lives. Most of us harbor them, but most of us don't have, problems with them typically. And these chronic reactivators are just not going to show you what you need to know on traditional antibody testing or serology. So I use those lymphocyte tests and I cross-reference them with the tick-borne infections and try to get a clue in of what's being attended to, so to speak. And sometimes I'd be surprised somebody went through a bunch of tick-borne treatment. It's their viruses that are lit up like crazy, or that post-COVID syndrome. Those viruses are very common. Once again, you can't assume they're always there, but they're there a lot. So you just kind of play it out. And sometimes you do have to trial treatment with antivirals in some cases and stop the replication for a little while and see what happens. And that can agitate the heck out of the immune system or the brain or the bugs. But you do it appropriately, and it can be a trial, that you can perform too.
Okay, this is a long one. How could a teenager or young adult, for example, with so many symptoms, who has no idea if one of their parents had Lyme or co-infections passed on to them while in utero so many years ago, how could they, if they actually have one, know if they have one or more in their body? I would think with all the biofilm layers developed over the years that no test can confirm. Or are there certain tests that would confirm or indirectly highly suggest Lyme or co-infections decades after birth?
That's a good question. I mean, I think you might have to provoke it sometimes in those cases, but it's really hard to say. There are ways to quote unquote provoke testing with therapy, and that can be either biofilm agents in that case, if you're worried about biofilms, or antibiotics or antimicrobials prior to doing testing. And it depends on the test that you're doing, but almost any of them theoretically could receive, or could create a response with provocation. But beyond that, there are direct tests that are newer that may or may not pick something up here too, like the culture enhanced PCR, if there's even one cell floating around somewhere. That's like the new IGeneX test. Classically for kids, like young kids, we'd use the urine tests. And even though they weren't perfect at telling us if the bugs were alive or not, they were a low invasive screen to see if there's DNA somewhere in the system. So that would suggest that there was an exposure at some point. So even in like a 2-year-old, you might find a urine test with positive, Lyme OSP or something like that. So then you correlate that to clinical findings, of course, and you don't just, go always treating, because plenty of people harbor these organisms and that's not the primary cause of their problems, but it is suspicious if they are symptomatic, of course.
Do you have any recommendations on ways to naturally help the body rebuild and fight microbacteria that actually have proven to work? Many clients I have been sick for some time and not able to work. Family members don't seem to see the issues externally and think family members are just exaggerating their issues.
So that question was about kind of like social support.
I think it's a yes. And then it started out talking about how to fight
Oh,
microbacteria.
okay, that's where
And
I got
then it went,
confused.
yeah, and then it went to, it seemed like social support.
Okay, well, I'll answer the first question first, I guess. So microbiome is interesting because everybody has a unique microbiome we inherit from our mother and gets altered through the course of our lives. And incidentally, our partner, whoever we hang out with the most, we both end up looking very similar from a microbiome signature. So we also kind of adapt and change in that way based on our environment, what we're eating, and who we're around, and all that kind of stuff. So it's pretty fascinating. So usually you do a individual mapping for somebody and you kind of see where the imbalances are lying. What we're looking for is relative biodiversity in the microbiome. And There are some cool tests like the biome effects or other ones that are just not pathogen based, but rather just like a next generation sequencing, like massive map of microbiome. And the more you learn about those, the more you can see. But it's obvious in folks that have been chronically ill or have gone through multiple courses of antibiotic treatments that there's something missing in there. And it's not just giving probiotics to people, it's often giving prebiotics to people through both dietary arrangements and sometimes supplemental. And if it's really severe, that's when you can use your partner's poop to get an FMT or something. But that's harder to do in this country right now unless you have C. diff. But if you have C. diff, I know someone. But I also, yeah, work a little bit with Dr. Sabine Hazen, Dr. Hazan, and a gastroenterologist that does microbiome, related therapies and stuff, a researcher. So, there's a lot of things, but we see absence of bifido and all that. As far as the social support goes, that's really challenging. I think that in some cases, people do well, like with finding, people online or other places. In some cases, that's not always like the best thing for people too, because the online world can be kind of a mixed operation. But people do, find community or like-minded folks that at least, can commiserate in some ways there. But I think really, as far as their community goes, it'd be nice if I was like in their community working with them more. I think I would be able to like probably integrate more with their psychotherapists and other people. I think that once again, if I can talk to their therapists and other folks, I can get more insights into those dynamics, or a social worker possibly even. I mean, in an ideal world, we would need more than one person sort of in play here to help these people. And otherwise, I talk to the family, honestly. I mean, I do. I just talk to them. If they want to come to a visit, I talk to them. And they might not understand it at first, but I think if I continue to drive it home a little bit, and I usually do that in a pretty nice, sort of basic sort of way. I don't like overwhelm them necessarily. I'm just like, this is what we're seeing, this is what we know. And if you want more literature on this, here's a bunch of resources. And I think, iLads even has like some little like brochures and pamphlets for family members to understand things, because, some people do better in a brochure. So it's mostly education as a driving force for getting that to go in the right direction, but sometimes it is also working with local community members and practitioners and stuff too, and trying but if I could talk to the family directly, I'm beelining it straight into that.
Great. How do you determine if and when IV antibiotics are necessary, and if so, for how long?
Yeah, that's a good question. I mean, I think that if they're in the more acute phase and they've just sort of failed oral treatment, or their gut's just not operating correctly with it, or I think that they're just getting absolutely no use from it whatsoever, then, I might jump to IV antibiotics if they're kind of more semi-acute. And by that, I mean maybe in the first year or something, or if it's like relatively newer. If they've never done IV antibiotics and they've clearly benefited from antibiotics in the past, orally or otherwise, they just haven't gotten far enough with it, I might entertain the thought there. And then if they're in like a major acute flare that's determined to be infection driven, that I feel is, dangerous or problematic for their system, I might intervene at that level too. So there's a multitude of factors of how I decide if IV antibiotics are appropriate. But I'll usually go through that general sort of thought process. But if I'm unsure and I think that maybe the bugs aren't the primary issue, I'm not just going to like rush into it either usually.
Great. This individual has been in Lyme remission for 5 years, but still is having neuro symptoms, headaches, brain fog, insomnia. What do you suggest testing wise or treatment wise?
Headaches, brain fog, insomnia. Well, in those cases, I think nutrients are still important foundations. I do a lot of like nutrient repletions and stuff for people because they can become very depleted. And I think looking at that interface with the neurochemistry is important. And if their gut's been not operating effectively, there can be some basic things to look at, even just minerals and things of that nature there. I will also look at toxin discussion once again if it hasn't been appropriated, and those can be environmental influences like chemicals and sometimes EMFs. And some people, it can be a lot of different things that are really not obvious to them that might be triggering them, that's developed out of Lyme, but it's Lyme sequelae, it's not Lyme anymore. It's that sort of echoes of Lyme sort of idea where they don't really have it anymore, but they have that, maybe it's that PTLDS diagnosis once again, whatever you want to call it. But brain retraining systems, plasticity treatments, there's maybe hyperbaric or maybe regenerative support, maybe exosomes or stem cells. It could be 1,000 different things at that phase. But I would reevaluate them first and kind of see, there's still infection activity? Sometimes there really isn't. There's no evidence of it. depending on what's worked for them before, in terms of testing too, because maybe the testing didn't work. And kind of just go through that operation. So it's definitely not impossible. It's just more challenging because you got past the phase of like 1+1. Hopefully you could so many more variables in that particular equation at that point. It could be the hormones in that individual, could be 1,000 different things. You have to go through all the body systems and figure out what needs to be rehabilitated, because Lyme can definitely, cause a problem for multiple systems.
This individual tried to push through 8 months of the Dapsone protocol, but had to stop due to worsening neuro symptoms. Sleeping was not great before, but can barely sleep now. Getting off of the protocol hasn't helped. Do you have any recommendations for next steps?
Yeah, that's a good question. Yeah, that's one of those cases where I would look at, yeah, I mean, I might look at like autoimmune encephalitis type things too and see if there's, a flare from the treatment that was secondary there. I've had a few people with autoimmune manifestations get substantially worse after trying a treatment that was more aggressive. And I've seen those people before. And so, I might run a Cunningham panel, or like a Vibrant Neural Zoomer is pretty cheap to run. I might look and see if there's like an encephalitis response that's happening there, because there might be ways to calm that down. Like there's higher interventions like IVIG and apheresis and stuff if it's really, really bad. But those are expensive and less accessible therapies. There might be, cheaper, easier options, but I would look into that arena. I would look at mast cell disorder, trialing stuff there for inflammation reduction. I would figure out how to get the fire under control before I would revisit infection treatment, though. That's what I would try.
All right. What about a prehab for biofilm? Biocidin, LSF, oregano oil, stevia, and for the microbiome ahead of treatment for the Lyme.
Yeah, it's a good idea. I mean, some people pre-treat with biofilm stuff, whatever that may be, for like 30 to 60 days before doing an infection treatment. So it's not unheard of. I use a variety of different tools. I mean, I have used biocidin, I've used essential oils and stuff like that. I've used silver, like Argentine silver, lower parts per million, whatever. I've used bismuth-based systems, especially when there's like gut stuff, but the bismuth subnitrate DMSA ALA combination, designed by Paul Anderson, that was called Biosolve, is pretty powerful. Enzymes are really quite powerful. You might get the Interphase or any of those types of brands, but you go low, slow at first with it. Some people do an aggressive like punch load, like 1 or 2 weeks, and then they like taper it down. But you don't have to treat biofilm stuff every day of the week. But you can do it until symptoms start to heighten and then hammer it if you want to. There's a lot of different ways to manage biofilms, but I definitely keep that on my radar, especially there's a lot of gut stuff, because that's where most of the biofilms are considered to really thrive.
All right, to wrap up, let's go with sort of an overview probably of how can we reduce inflammation in the brain from neuro Lyme? Are there some basic rules?
Sure. I mean, I think generally speaking, understand the environment that one's in and how that's serving the brain or not serving the brain. That can be toxin, or that can be, non-toxin, toxic people possibly. It can be a lot of things. Make sure that the environment is more conducive for healing. I think that really helps a lot. Understand the toxin landscape as at large if you can, mycotoxins, molds, and various things like this, because it's probably affecting the brain in some capacity. Look at the gut-brain interface and try to understand where you need to intervene there and sort of chip away and make some, take some action. You can use substances that reduce inflammation, like the turmeric, curcumin, boswellia combinations, and use peptide therapies. I didn't talk about them extensively today, but regulatory therapies to try to get the brain processes and the inflammation back online, or the immune system as it stands, and kind of just go down that road and see where it can take you. And if there is a bigger intervention that's needed, like I said, investigate the autoimmune encephalitis possibilities that may be present there, if it's a really persistent syndrome, or if there is neuropsychiatric manifestations or things like this. Understand what the full spectrum of possible intervention might be, and start off foundationally and sort of build up through that process. It's kind of just, classic naturopathic philosophy, actually.